Shall I start the
Uh,
presentation? Thank
One
you.
second. Yeah, Divya's joined. So start off.
Yes. Good morning, everybody. I am Mayur. Today I will be discussing regarding lower body Parkinsonism, its mimics, with the help of some case vignettes and videos. My moderator is Dr. Divya KP. Coming to the definition, lower body Parkinsonism is a clinical condition which is characterized by Parkinsonism features with predominant involvement of the lower limbs and sparing or minimal involvement of the upper limbs. The lower body Parkinsonism patients form a distinct homogeneous clinical group. They show disproportionate lower body gait difficulty, rapid progression of the symptoms, poor response to levodopa therapy, and there is a high hypertension prevalence in these patients. The common causes of lower body Parkinsonism include normal pressure hydrocephalus, that is NPH, PSP, progressive supranuclear palsy, and vascular Parkinsonism. There are other causes like frontal lobe lesions, tumors, infections, and demyelination, which could also cause lower body Parkinsonism. The discussion in this class will proceed in the manner of discussion regarding NPH, PSP, and vascular Parkinsonism, and a small approach to the lower body Parkinsonism symptoms, how to approach the patients. Coming to the PSP, I would like to start with a case scenario. A 75-year-old man presented with 1 year history of progressive difficulty in walking and increased urinary urgency. He struggled with walking on uneven surfaces, turns, and getting out of chairs and cars, and has also started using a cane after two falls. For 3 months, his verbal responses had been slower, and he also reported urinary urgency and frequency with occasional episodes of incontinence. On examination, a cognitive examination was done using a MoCA score, Montreal Cognitive Assessment, and was found to be 22 out of 30. He has lost points in executive and verbal memory domains. On gait examination, he had a magnetic white-based gait characterized by small shuffling steps and difficulty initiating movement. Here is a video in which we could see the patient's gait. Uh, the gait in NPH is classically described as a magnetic gait and gait apraxia. Here we can see that the patient is having short steps and sudden freezing of gait, which is mimicking a Parkinsonism, which is the freezing of gait as a classical feature of Parkinsonism. And he is not able to turn and he is not able to take the steps forward. The step height has been decreased in this patient. The step length also has been decreased. The speed of walking is decreased and balance is impaired while walking. Here we can see the magnetic gait, in which the patient is not able to lift his legs above the ground properly. Uh, that was the case. Now coming to the disease per se, normal pressure hydrocephalus is a clinical syndrome characterized by the triad of gait apraxia, cognitive impairment, and bladder dysfunction in the radiographic context of a ventriculomegaly and normal intracranial pressure. This condition is considered to be one of the reversible causes of dementia and impaired gait. In 1965, Hakim and Adams first described normal pressure hydrocephalus. Currently, it is classified into idiopathic NPH and secondary NPH. Secondary NPH is generally due to other causes like subarachnoid hemorrhage, meningitis, infections, trauma-related obstruction due to which there could be a secondary NPH. Coming to the epidemiology of the disease, there were early Norwegian study in which those were the early studies in which NPH was studied, and the incidence was found to be 5.5 per 1 lakh population per year, and the prevalence of 21 per 1 lakh population. In a recent 2020 systematic review, the prevalence of a probable NPH was 10 to 22 per 1 lakh population, and prevalence of a possible NPH was 29 per 1 lakh population. The age-specific prevalence rises with age. Coming to more recent studies in 2024, a population-based imaging study was done in 70 years old, 1.5%, that is 1,500 per 1 lakh population, had notably higher prevalence than previous estimate. There were imaging findings which was suggestive of NPH and were seen in about 5% of this population of this age group. Now, coming to the the etiopathogenesis of NPH is due to the disturbance in CSF circulation. The CSF production is not equal to reabsorption. This is the rationale behind shunting. Then what causes the disturbance is not clearly known. There are multiple hypotheses which have tried to explain this, like meningeal thickening, arachnoid inflammation, and subependymal gliosis. The pathogenesis involves mechanical and ischemic factors. There is a ventricular enlargement which is caused due to tangential stress and vascular stretching. The high pulse pressure leads to local barotrauma, or the barotrauma is due to the tangential shear stress. It has been postulated that the purpose of the shunt is to add additional capacitance to the system, which increases the perfusion and not to decrease the pressure, because the pressure here already, as the name indicates, is normal. Coming to the pathogenesis of the disease, the classical triad includes gait disturbance, urinary disturbance, and dementia. The gait disturbance is due to the fibers of the corticospinal tract that supply the motor function to the legs pass closest to the lateral ventricle in the corona radiata. It is usually the first symptom to appear and the first one to resolve following a successful ventriculoperitoneal shunting. Coming to the urinary disturbance, there is urgency in the early stages. It is due to the involvement of the sacral fibers of the corticospinal tract, and there is incontinence. The incontinence could be disinhibition, which could be a feature of dementia also. The dementia is due to the disruption of the frontal subcortical circuits adjacent to lateral ventricles. This is the three classical features have been described with Hakim's triad, that is gait disturbance, cognition, and bladder. Coming to the frequency of the symptoms, the gait disturbance is most readily recognized component. Up to 95 to 100% of the patients have seen, and it is the first to appear, as previously discussed. And cognitive impairment occurs in up to 78 to 98%, and urinary dysfunction up to 76 to 83%. All three components need not be present for the diagnosis of NPH, and it has been seen that up to 60% of the patients do exhibit all three components together. The diagnosis is mainly based on history, clinical features, and imaging features, and it has been categorized into probable NPH, possible NPH, and unlikely NPH. On the right side, we do see a diagram in which the possible NPH includes one of the core symptoms out of the three mentioned, that is one clinical indicator, and probable NPH includes two of the core symptoms, and asymptomatic ventriculomegaly can also be seen, which is a separate entity. Unlikely NCH does not include any of these features. Coming to the history, the reported symptoms should be corroborated by an informant which is familiar with the patient's premorbid and current condition. The points which we should include are insidious in onset of the symptoms of more than 40 years of age, the minimum duration of the symptoms of at least 3 to 6 months, and there should be progression of time. There should not be any evidence of any antecedent event, head trauma, like a trauma, intracerebral hemorrhage, or meningitis, or any other known causes of secondary hydrocephalus. No other neurological or psychiatric or general medical conditions that are sufficient to explain the presenting symptoms. Coming to the gait disturbance, the gait is actually a higher level gait disorder due to disturbed postural and locomotor reflexes in the absence of primary sensory motor deficits. The primary sensory motor testing would be normal in these patients. There are also involvement of there is also hypothesized that there is involvement of frontocerebellar pathways, frontal periventricular corticobasal and ganglia thalamocortical pathways, and corticocortical fibers that project into the frontal cortex. Here is a diagram which is showing the gait difference. The middle one is the normal patient in which we can see the stance and stride having step length will be normal. In the gap between the 2 feet are well placed without any overlap. In Parkinsonism disease, which has been classically described as a fascinant gait, there is short shuffling gaits which is close to the both of the legs are close to each other. But coming to the normal pressure hydrocephalus, the gait is in these patients are wide based with outward facing of the feet. There is A decreased step height and decreased step length, as we previously discussed in the video. And there is decreased cadence, that is the speed of walking. There is impaired walking balance also seen. These are the features in which we see usually in uh, gait of the normal pressure hydrocephalus patient. At least two should be present, and the two entities which are present should not be entirely attributable to other conditions. The first one is retropulsion, which could be spontaneous or provoked. Second one is a widened standing base. Third one is the toes being turned outward on walking. Fourth one is decreased step height, and the fifth one is decreased step length. There is decreased speed of walking also in the form of decreased cadence, increased trunk swaying during walking. There is impaired walking balance, that is two or more correction out of eight steps on tandem gait testing. There is en bloc turning. When the patient tries to turn 180 degrees, there will be three or more than three steps, which uh, which is due to the difficulty gait. After testing of the gait, we also do some bedside testing which are named such as timed up and go test. The patient is made to walk 3 meters to and fro, and a normal patient should be able to do it within 12 seconds. There is also a dual timed up and go test in which we ask the patient to also do mental arithmetics, that is serial subtraction, in which this is also impaired in the patients of NPH. There is a 10-meter walk test. This is a test of gait speed. This measures the time needed to walk 10 meters from a standing start. The healthy older adults can complete it less than 10 seconds. Coming to the fourth one, the four-stage balance test, we do place the patients to stand in particular positions such as feet touching each other, instep of one foot touching heel of the other foot, a tandem stance or a one-foot stance. We see whether how much disbalance the patient is having in performing these standing tests. Coming to the second symptom, that is bladder dysfunction. The bladder symptom can present as an urgency in the early stages without incontinence and frequency, which is particularly noted during the night. And there also is urinary incontinence, which occurs at the late stages. During the by the time the patient has incontinence, he is aware and concerned about his symptom. And a particular incontinence without awareness of urinary urgency is not characteristic of NPH. Coming to the cognitive decline, there are features of frontal subcortical dysfunction. There is documented impairment or decrease in the performance on a cognitive screening instrument. There is evidence of at least two of the following that is not fully attributable to other conditions, which include psychomotor slowing, decreased fine motor speed, decreased fine motor accuracy, difficulty dividing or maintaining attention, and impaired recall, executive dysfunction impairment such as multi-step procedure impairment, working memory impairment, formulation of abstracts or similarity, and impairment in insight. There can also be seen behavioral or personality changes in these patients. There is impaired expressive or receptive language, impaired naming, agnosia, poor immediate recall that does not benefit from proving, and hallucinations also seen. Coming to the imaging in NPH, I have tried to describe it a little bit extensively. There are linear measurements of ventriculomegaly which have been mentioned in the NPH patients. The first one coming to the left side, figure A that we can see, is measuring the Evans index. It is the ratio of the greatest width of the frontal horns to the inner table of the calvarium on the axial slice. Here, A by B is Evans index. If more than zero point 0.3, it is significant. And coming to the right side image, it is Z Evans index. It is the maximum height of the frontal horn of the lateral ventricle, which is divided by D, which is showing the vertical diameter of the inner table of the skull till the base of the skull from the top of the vertex. And this is called as Z Evans index. The cutoff value for Z Evans index is 0.42. Coming to other measurements, so this is the callosal angle, which is the angle between the superior walls of the lateral ventricles that line the inferior portion of the corpus callosum. And uh, the, uh, the the right side diagram shows a photo in which MRI that we are showing. It shows the frontal occipital horn ratio. It is the average of the frontal width and the occipital width, which is summed as E by G, and the mean is calculated. And then it is again divided by the diameter of the inner table of the calvarium. The values of this which have been described are 0.48. The cutoff is described as 0.48. Coming to the next value, we have brain per BVR, which means brain per ventricle ratio. It is the ratio of the height of the parenchyma above the superior aspect of the lateral ventricle, either at the anterior commissure or the posterior commissure, and it is divided by the height of the lateral ventricles. At the anterior commissure, the cutoff is 1.0, and at the posterior commissure, the cutoff is 1.5. These were the linear measurements, and coming to the imaging features of DESH. DESH means disproportionately enlarged subarachnoid space hydrocephalus. Here we can see in the figure A, there is an axial section T1 weighted image at which we can see high convexity tight sulci. And this dotted circle which is showing a focal sulci dilatation. And coming to the B, again, there's a coronal section in which we can see the high convexity sulci. Here, the arrow is pointing the big arrow is pointing towards the Sylvian fissure, which is dilated. Coming to the C, again, we can see the same features in the lateral cuts from the sagittal section. This is showing the Sylvian fissure, and this is the focal sulci which has been dilated. Actually, in 2017, there has been an attempt to uh, develop a INPH RAD scale to standardize the quantitative measurements and to aid universal interpretation of CT or MRI in the diagnosis of idiopathic NPH. These are the components. I would like to try to explain each of them with a separate figure. The scale comprises of seven different imaging findings of idiopathic NPH, in which points are given for each feature, and the total sum is made of the for the final score. A score of four or more corresponds to a 100% sensitivity and 96% specificity for distinguishing definite NPH versus asymptomatic controls. Coming to the first one, the events index, it is the same as the linear measurement we discussed previously, in which the cutoff is zero point 0.3. We give 2 points if it is greater than zero point 0.3, 1 point if it is 0.26 to zero point 0.3, and 0 points if it is less than 0.25. Coming to the second one, this is high convexity tight sulci. It is evaluated using axial slices at the vertex and perpendicular coronal slices through the foramen of Monroe. 1 point is given if there is a parafalcine sulci narrowing, that is here, and 2 points if there is a vertex sulci narrowing, which is here. And coming to the Sylvian Fisher points, it is assessed in a coronal plane through the center of the brainstem and sagittal planes at the midpoint between skull and the insular cortices on either side. If the Sylvian fissures are dilated more than the surrounding sulci, like as we can see here, a score of 1 point is given. Coming to the next scoring system, focally enlarged sulci. It is evaluated both in coronal and axial planes, and if presence of one focal enlarged sulci is seen, then 1 point is given. At least one should be there. Coming to the callosal angle measurement, if this is here is how we measure the callosal angle. If it is greater than 90, then it is given as 0 point. If it is less between 60 to 90, it is given 1, and if it is less than 60, then it is given 2. And coming to the width measurement of the maximal diameter of the temporal horns, which is again measured in the axial plane. If it is more than 6 mm, it is given 2. If it is between 4 to 6, it is given 1 point. And if it is less than 4, then it is not given a point, 0 points. The last component of the NPH RAD scale, which includes Fazekas grading. There are periventricular white matter lesions evaluated using the Fazekas scale. 0 points are given if there is Fazekas 0. 1 point is given if the patient has Fazekas grade 1, and 2 points are given whether the patient has Fazekas grade 2 or Fazekas grade 3. The total cutoff score of grade 8 or greater provides the highest probability of idiopathic NPH with a positive likelihood ratio of 11.5. Coming to the CSF studies, CSF opening pressure is the physiological criteria for diagnosis of NPH, in which, as the name suggests, the pressure of the CSF on measurement would be within the normal range. And following which, we do CSF for CSF tap test to see for shunt responsiveness. The shunt responsiveness can be measured by CSF tap test, extended lumbar drainage, and also a measurement of CSF outflow resistance. The opening pressure in normal individuals is 8 mmHg plus minus 0.9 mmHg. In normal pressure hydrocephalus, there is mild elevation, but the values overlap with the normal range of the pressure, that is 5 to 18 millimeters of mercury. In appropriately measured pressures, significantly higher or lower than this range, which are not consistent with a probable NPH diagnosis, can be considered. The tests of shunt responsiveness are done with a rationale to emulate the physiological effect of a shunt. That is, again, the CSF tap test, external lumbar drainage, and CSF outflow resistance. If there is response on CSF tap test, the shunt surgery should ideally help. But if no response, it is the notion that shunt surgery is unlikely to help is wrong. I have tried to present the studies which have supported this statement later. The volume of CSF which should be removed in the CSF tap test must be adequate to influence the NPH symptoms and long enough to assess the change. That is 30 to 50 ml of CSF can be tapped, and patient must be examined before and after the LP. Ideally, videographically, the gait should be measured. Along with that, we can also measure his cognitive status using standardized scales such as MMSE or MoCA. MoCA is preferred to over MMSE because MMSE is more towards the Alzheimer's disease scale, but the subcortical components of executive function are better measured by MoCA. Here, the patient must be examined before and after, as stated here. The interval is uh, post 30 minutes to several hours. He can be assessed for improvement. And change in gait and cognition is what we primarily see. Coming to treatment, there is no medical treatment which is effective on idiopathic NPH as of now also. But surgical therapy can be done in which CSF shunting is done by ventriculoperitoneal shunting, ventricular atrial shunting, and lumboperitoneal shunting also. The goal of the shunt surgery is to improve the patient's symptoms and avoid the complications of over drainage, such as subdural effusion or hematoma. There can be also placed adjustable shunt valves, which gradually lower the pressure setting until symptoms improve. And we can raise the pressure setting if low pressure symptoms or complications emerge. And it can be used safely to manage idiopathic NPH patients who also need chronic anticoagulation. Now, coming to the patient which we saw earlier, I would like to again show the previous gait in which he was having decreased step length, decreased height in the step height, and magnetic gait with gait apraxia. On the right side, we can see this patient was particularly placed a VP shunt. After 6 months of his VP shunt, which was programmable, he had a significant improvement. And turning also, we can see he can do better. In the first video, he is not able to turn. He's not able to maintain his balance at all. But in the right side video, he is able to turn well, and he can to and fro. His motion has been, his ambulation has been improved significantly. Uh, The patients were longitudinally followed up. Without surgery, most NPH patients had measurable deterioration as early as 3 months following an initial assessment. There was clinical benefit of shunting. Some patients did improve immediately after the postoperative period. Some patients did take up to 6 months to show signs of some improvement. There was some transient improvement and there was worsening within 6 months. But there have been data that benefit can be sustained for up to 5 to 7 years in patients who have been who have been given ventricular shunting. In patients who worsen even after ventricular peritoneal shunting, we have to evaluate to rule out any possible shunt blockage. It is the clinical picture of the patient and not the size of the ventricles that should determine the outcome and whether an intervention is needed or not. The gait is the easiest symptom to follow objectively. As mentioned earlier, the 10-meter walking test can be done, and number of steps taken and the time necessary to cover this distance can be recorded and followed up on assessment. I would like to show a study which was published from Europe, which was the European NPH multicenter study on predictive values of resistance to CSF outflow and the CSF tap test in patients of idiopathic NPH. The objective of the study was it was a large prospective blinded study on values for route and CSF tap test for predicting the effect of the shunt surgery in idiopathic NPH. Route was the pressure resistance of of the CSF which was measured. There were 115 participants with idiopathic NPH which were taken into the study. The mean age of the patient was 70 years. They were followed up 12 months after the surgery. The predictive performance of these tests were showing weak correlation between the tests and the outcome. Only a small correlation between the improvement of the gait after CSF tap test and post-op improvement was seen. The p-value was 0.02. The implications were the CSF tap test had high positive predictive value of more than 85% and low negative predictive value, that is less than 20%, because many patients with negative test results still improved after surgery. The ultimate clinical message that we can derive from this is these tests can help support and decisions, but would not exclusively used to exclude patients from the surgery. The decision to shunt or not should still rely heavily on the clinical and imaging findings of the patient. This was regarding the NPS, normal pressure hydrocephalus. Now I would like to tell about the second entity which can present as a lower body Parkinsonism, that is PSP, progressive supranuclear palsy. Again, I would like to start with a case scenario. A 65-year-old man presented with a 2.5 year history of unprovoked falls, occurring both backward and forward. He would quickly stand up on his heels from a seated position and often fall back into the seat. This has been described as a rocket sign, and while eating, he began to leave food on the part of the plate closest to him and developed messy eating habits with overstuffing his mouth and spilling of food onto his clothes over the last 6 months. He also became more withdrawn and participated less in conversations less frequently, and also developed a tendency to laugh at inappropriate times. He denied loss of smell or dream enactment. The patient had no family history of Parkinsonism, Parkinsonian disorders, or dementia. On examination of the patient, he was fully oriented and had scored the 23 out of 30 in the MOCA assessment, with points which were lost for visuospatial and executive function, attention, and verbal fluency items. The ocular pursuits on examination were partially limited in the vertical plane, with intact oculocephalic reflex, and gross saccade testing revealed selective slowing of and amplitude reduction of downward saccades when compared to the horizontal saccades. He also had mild hypomyemia with reduced blink rate and moderate hypokinetic dysarthria. He had moderate neck rigidity with mild leg rigidity, while the tone of the arm was within normal limits. There was mild moderate hypokinesia out of proportion to slowing on finger and toe tapping. Tremor and dysmetria were, however, absent. He was unable to rise from a chair without the use of his hand. His posture was upright and his gait was slowed with reduced stride and pulsions on turning. The pull test was positive and descent onto the chair was uncontrolled. Coming to the description of the entity, it was initially described by Steele et al. In 1964. 5% of the Parkinsonian patients are ultimately having PSP, diagnosed to have PSP. The male to female ratio is 1.5 to 1. The condition is commonly misdiagnosed as Parkinson disease. It is a purely clinical diagnosis, and it is almost always sporadic with a few familial cases reported. The postural instability and extra-Parkinsonism, extrapyramidal features in this condition are there are falls which are predominantly backward. The rigidity is axial more than appendicular. The speech is hypophonic. The gait is wide-based and ataxic. There are also appearance of frontal release signs and pseudobulbar palsy, as seen in the patient case described. There is levodopa unresponsiveness, which is a characteristic feature of PSP. The early signs in the PSP are there are slow vertical saccades and square wave jerks, which I will be describing in detail shortly. There is reduced blink rate and apraxia of eyelid opening. On doll's eye maneuver, there is improved range because it is a primarily a supranuclear problem. And the dementia is again subcortical in this patient also, in this condition also. The typical faces of PSP are having a surprised look. And in advanced PSP, there is also a complete ophthalmoparesis seen. Coming to the gait of PSP, it is stiff and broad-based gait with a tendency to have the knees and trunk extended and arms having slightly abducted. That while turns, they tend to pivot instead of turning en bloc. And the posterior instability of these patients have frequent and early falls. Usually, the falls are backward. In 2006, Williams et al. Had published a finding that the time of symptom onset to the first fall is significantly less in PSP patients when compared to other entities which have similar presentations like vascular Parkinsonism, MLA, DLBD, and PD. The falls in PSP are impaired response to the disequilibrium. And there is a loss of anticipatory postural reflexes with loss of protective reaction, and also related to supranuclear ophthalmoparesis, axial rigidity, and impaired judgment and insight. For example, when they try to get up, they inadvertently extend their trunk and the neck fall, extend the trunk and neck, and tend to fall backwards. The patient does not use his arms to keep balance while negotiating unsteady or narrow passages. They fail to throw out their arms and brace while falling, which results in greater injury. There is a NINS criteria which mentions probable PSP having falls within 1 year, and the more recent MDS criteria mentions probable PSP having more than one unprovoked fall or tendency to fall, if not caught by examiner on pull test within 3 years of the onset of symptoms. Coming to the oculomotor abnormalities, there is a supranuclear gaze palsy in which there is impaired range of movement. There is a limitation of the range of voluntary gaze in the vertical more than horizontal gaze. It starts with down gaze restriction and it is overcome by activation with the vestibulo-ocular reflex, which is again lost in the later stages. Here I would like to show the video of the oculomotor abnormalities. In this, the patient's pursuit is being tested in the horizontal plane. He is able to follow. But when tested to be in the vertical plane, he is not able to follow the finger due to paresis. Up gaze is more affected in this patient than down gaze.
The video is not working.
Audio, audio is not there, madam.
Video is also not moving. Is it moving?
Video is play.
Just play it one.
Now also it is not. I have one more video of the gaze abnormality.
Okay. So,
The in that I will show.
fine.
Uh, There is reduced velocity and amplitude of the vertical saccades, as seen in the video. To be diagnostic, the saccadic movement should be slow enough for the examiner to see the movement. A mere delay in the second initiation is not considered as slowing. The other supportive findings, such as slowed or absent fast components of the vertical optogenetic nystagmus, that I have tried to show in one more video. There is also appearance of macro square wave jerks. These are rapid involuntary saccadic intrusions during fixation, displacing the eye horizontally from the primary position and returning it to the target after a span of 200 to 300 milliseconds. It is very rarely seen in normal individuals, and even if it is seen, it is less than 1 degree. But in the patients of PSP, it is very frequent at a frequency of more than 10 per minute, and the the amplitude also increases. That is, more than 3 to 4 degrees of the square wave jerks are seen. Uh, Coming to the next abnormality of the oculomotor part, that is apraxia of eyelid opening. There is inability to voluntarily initiate eyelid opening after a period of lid closure in the absence of involuntary forced eye closure, which is a peripheral spasm. There are cognitive symptoms in which there is frontal dysfunction, which manifests as executive dysfunction, impaired abstract thought, decrease of verbal fluency, and motor perseveration. There is behavioral disturbances and primarily apathy, but also depression, disinhibition, and anxiety. A frontal assessment battery testing was done, and a cutoff of 15 was shown to differentiate patients with PSP from individuals of PD or MSA in a study done by Paviour DC et al. And the lexical fluency and motor programming subscores selectively are more affected in patients with PSP. Coming to the extrapyramidal signs, there is akinetic rigid parkinsonism, axial more than appendicular rigidity, and levodopa resistance. Dystonias in the form of blepharospasm, frontalis dystonia, procerus dystonia, retrocolis, and limb dystonia are also seen. Uh, the faces in PSP are astonished or having a worried look. There is a particular procerus sign which has been described. Here is the procerus muscle, and the vertical ridges is what distinguishes procerus from the frontal furrowing. So video.
Again, the same problem.
This video is playing.
Yeah, okay.
In this again, we have the examiner is trying to test the he tried to test the horizontal movements of the patient, and now he's trying to test the vertical movements in which she is able to see towards the downwards, but she's not able to look upwards at all completely. And now he's testing the optokinetic nystagmus in the vertical plane, which is almost normal. We can see slight jerky movements. And now he is trying to test it in the vertical plane, in which there are no jerky movements, but there is slow up gaze and down gaze. Here he is trying to attempt to see the postural stability of the patient in by doing a pull test. But this patient is severely affected by PSP, and usual tug which is given during the pull test is not required, and she is already falling back. Here we are again seeing that the examiner is testing the rigidity of the patient. The axial rigidity was more than the appendicular rigidity in this patient. Here, bradykinesia, this patient is having severely affected bradykinesia of both the upper limbs and lower limbs also. He had bradykinesia. And leg agility, as we test in the QPDR3 for Parkinsonism, was severely impaired in this patient. Uh, there was a sudden uprise in the instability while sitting down, which has been mentioned as a rocket sign. And this patient is particularly being supported because he cannot sit by himself. At the last, he is trying to demonstrate the applause sign, in which the patient does not stop after clapping when told to clap for 3 to 4 times, but he continues to do so by himself. This is a sign of perseveration. Coming to the imaging in PSP, there have been name signs which have been described in PSP, such as the hummingbird or penguin sign. It is seen on the mid-sagittal plane due to midbrain tegmental atrophy. The most rostral midbrain. This is the normal image that we are seeing, and in the center we are seeing the patient image of the patient with PSP. The most rostral midbrain corresponds to the bill of the hummingbird, and the midbrain tegmentum. The midbrain tegmentum corresponds to the head. The midbrain tegmentum corresponds to the head. The body of the pons corresponds to the body of the hummingbird, and the cerebellum corresponds to the wings, shown here. The next sign is the Mickey Mouse sign, in which there are prominence you can see the prominence due to selective atrophy of midbrain tegmentum and preservation of the tectum and cerebral peduncles. That's why it is looking like a Mickey Mouse sign. And coming to the third sign, there is a morning glory sign. A horizontal line is drawn to the edge of the posterior surface of the cerebral activator, and a second line is drawn along the lateral margin of the tegmentum from the intersection of the horizontal line to the pit between, here it is more clearly seen, the pit between the tegmentum and the cerebral peduncle. In the normal subjects, the lateral margin of the tegmentum is convex and runs outside of the second line. But in patients with supranuclear palsy, due to the atrophy, the line runs concave and inside. So this is the morning glory sign which has been described. One more sign has been more classically described as midbrain to pons area ratio. The base of the pons and the base of the midbrain, the ratio is showing if it is less than 0.15, the cutoff has 100% sensitivity and specificity for the diagnosis of PSP. Next, we come to the management of PSP. The only levodopa has had reported response rates of that also up to 25 to 38% at a dose of 1,500 milligram per day. The effects, however, are short lasting, and out of the multiple PSP variants in PSP Parkinsonism is more responsive in the initial stages. The reason is that there is a marked loss of the postsynaptic D2 receptors, which is secondary to the loss of postsynaptic striatal neurons. A trial of at least 2 months at the highest tolerated dose, usually around 750 to 900 milligram per day, is warranted in these patients. The NINDS SPSP, Society of PSP Criteria definition of levodopa trial. says that it should be tested with at least a maximum tolerated dose or at least 1 gram of levodopa, which is administered 2 to 3 times per day for at least of 2 months duration. The response to levodopa is considered poor when the extrapyramidal symptoms fail to show marked improvement or if the therapeutic effect is transient, that is, which lasts only less than 1 year. The other options which could be tried is botulinum toxin, which is useful for the management of blepharospasm and apraxia of the eyelid opening, and also drooling by salivary gland injection, also in drooling. The other medical management, the cognitive symptoms are usually resistance to the treatment measures. There is modest improvement in the cognitive state, which is observed after treatment with donepezil in patients with PSP. But routine use of donepezil is not recommended due to the risk of worsening of the motor symptoms, that is balance and swallowing, and in these activities of daily living. This concludes the second entity. Third entity which we are coming to is vascular Parkinsonism, which can present as lower body Parkinsonism. Again, I would like to start with a case scenario. A 71-year-old gentleman had presented with progressive difficulty in walking of 2 years of duration, which was insidious in onset, gradually progressive gait abnormality. Initially had slow, short steps and later had imbalance while walking, with a tendency to fall and difficulty in turning. Over the last 6 months, he also developed freezing of gait and feels that he has difficulty initiating gait. For the past 1 month, he also had required support to walk with frequent falls if not assisted. He also had complaints of urinary urgency and frequency with urge incontinence for the past 1 month. And particularly, I would like to show that he also had the hypertension and diabetes for more than 10 years, although on medications, with a past history of stroke, yeah, which was 2.5 years ago, with right hemiparesis, which he nearly completely recovered within 6 months. And he also has been a smoker of 2 to 3 cigarettes per day. These are the traditional risk factors, which are traditional vascular risk factors, which are seen in this patient. And on examination, he had stable vitals. The speech was normal with a MMSE of 28 out of 30. He had a reduced facial expression with normal blink rate. However, no upper limb rigidity or no upper limb bradykinesia was seen in this patient. He had mild postural tremors of both hands, but the tremors were absent at rest. There was mild to moderate rigidity of both lower limbs and moderate bradykinesia. All the diurnal reflexes were exaggerated, which were asymmetric in the upper limb and lower limb, right more than left. The right plantar was extensor and left was flexor. There was mild heel shin incoordination, and on gait examination, he had initial difficulty in initiating gait, required the support of one person to walk with short steps, reduced arm swing, and unblocked turning. Coming to the disease per se, vascular Parkinsonism is a type of atypical Parkinsonism in which the etiology is of vascular in nature and accounts up to 4 to 12% of all the cases of Parkinsonism. It is a clinical phenotype that is primarily characterized by gait impairment and is caused by pathology of the cerebral arteries and predominantly affects subcortical white matter. This is a criteria which has been described for vascular Parkinsonism, in which they have been divided into components as A and B. A refers to Parkinsonism, in which there is bradykinesia with at least one of the following of rest tremor, muscular rigidity, or postural instability. And the B includes evidence of cerebrovascular disease either by brain imaging, CT or MR, or any focal neurological signs or symptom which are consistent with stroke. And the relationship between A and B is what decides the vascular Parkinsonism to be of acute onset or insidious onset. The infarcts near the basal ganglia or the thalamus with an onset of within 1 year of stroke, and a contralateral bradykinetic rigid syndrome or shuffling gait is included in acute onset of vascular Parkinsonism. And in insidious onset, there is extensive white matter lesions seen with bilateral symptoms, along with early shuffling of the gait and cognitive dysfunction. Exclusion criteria of this vascular Parkinsonism includes a history of repeated head injury, a possibility of encephalitis, neuroleptic treatment at onset, the presence of cerebral tumor or communicating hydrocephalus on imaging, or any other alternative explanations for these Parkinsonism features. Lower body Parkinsonism presents with postural instability, shuffling or frozen gait, and minimal or absent tremors. There is poor or no response to levodopa at all. The presence of pyramidal symptoms such as spasticity, brisk reflexes, and cerebellar signs can be seen. The symptoms are usually contralateral to the white matter lesions, sometimes ipsilateral also can be seen. The gait is broad-based, slow, unsteady, and with frequent falls. Freezing of gait is common in this condition. Bradykinesia is more pronounced in the lower limbs than upper limbs. Coming to the cognitive part, there is dementia, pseudobulbar affect, and urinary incontinence often present. And there are also appearance of frontal release signs as seen in PSP. Abnormal glabellar tap, snout, and palmomental reflexes can be seen. The cognitive profile of the patient, when examined, shows severe executive dysfunction with impaired verbal recall and fluency deficits due to frontal and basal ganglia disruption. Here we are seeing the image of MRI brain, which shows diffuse cerebral atrophy with periventricular and subcortical white matter hyperintensities. There are multiple small infarcts seen in which uh, there is also grade 3 physical changes seen in this image. There has been mentioned a vascular rating for vascular Parkinsonism, in which pathological or angiographic evidence of vascular disease amounts to 2 points. Onset of Parkinsonism within 1 month of stroke has 1 point. History of two or more strokes has 1 point. History of two or more vascular risk factors for stroke again has 1 point. And neuroimaging evidence of vascular disease in two or more vascular territories again amounts to 1 point. A total score of two or more is consistent with is more supportive of the diagnosis of vascular Parkinsonism. Since vascular Parkinsonism is assumed to be caused by cerebrovascular disease, the principles of primary and secondary prevention of stroke also apply to the vascular Parkinsonism condition. If the lesions involve the nigrostriatal pathways, L-DOPA is found to be effective. In patients where other pathways are involved, of the other pathways of the white matter lesions are involved, levodopa has been found to be not effective. Coming to one more entity, Binswanger disease, it is a form of vascular cognitive impairment related to the injury of the small vessels of the brain, and it is characterized by extensive white matter hyperintensities with gradual subcortical ischemia. These patients classically developed focal neurological findings, gait disturbances, and cognitive impairment. They often have different degrees of cognitive impairment, and the history reveals past episodes of mini strokes or transient ischemic attacks that have been occurred. On examination, there are usually UMN signs which are asymmetrical hyperreflexia and mild Parkinsonism can be seen. The symptoms are steadily progressive but can show a waxing and waning patterns and sometimes a stepwise course. Hypertension is almost always present, and its absence should lead to questioning of the diagnosis of vascular Parkinsonism. The other traditional risk factors such as diabetes, prediabetes, smoking, hyperlipidemia, sleep apnea, atrial fibrillation, while common, are less helpful for defining of the disease. The executive function and processing speed are the most commonly affected cognitive functions in this condition. The cognitive decline occurs, but in a gradual, slow progression. For evaluation, we usually prefer MOCA to MMSE because, as previously seen for the case of NPH, this MOCA more tests for the executive function, which is more often abnormal in patients of Binswanger disease, a vascular cognitive impairment, making it a better screening test for subcortical dementia. Now, I would like to propose an approach which I try to make out based on these conditions for the diagnosis or management of lower body Parkinsonism. We should, based on the history, we should see whether the age of onset is the patient is elderly or younger. If he is elderly, it supports a vascular or NPH as a diagnosis.
Sanu, what is happening?
Screen share ചെയ്തിട്ടില്ല madam.
Hello.
Yeah, see. Carry on.
Hello. Sorry,
Yeah,
there was a
continue,
small
continue.
disturbance.
Continue, no problem.
I was talking about the approach to lower body Parkinsonism. Based on the history, if the patient, the age of onset of the symptoms is in an elderly patient, we can consider vascular Parkinsonism or NPH. If he is a relatively younger patient, then we can consider for atypical Parkinsonism. Based on the symptom onset, if it is a sudden or a stepwise progression, we can consider a vascular cause, and if it is an insidious or progressive symptoms, then neurodegenerative conditions can be considered. Coming to the risk factors, the presence of hypertension and diabetes suggest vascular etiology, which could support the possibility of a vascular Parkinsonism. And associated symptoms such as cognitive impairment and incontinence do support NPH. Early falls, as previously mentioned, do support the possibility of a atypical Parkinsonism, that is PSP. On examination of the gait assessment, short shuffling steps with widened waist gait is seen. There is postural instability, which is suggestive. If it is very early within the onset of 3 years of the symptom, then it is suggestive of PSP. There is a reduced arm swing, which may be still be preserved in pure lower body Parkinsonism. And the presence of pyramidal signs such as spasticity and hyperreflexia, these do suggest a possibility of vascular Parkinsonism. The eye findings, which we have been discussed in detail, should be tested if there is a suspicion of PSP, and if they are suggestive, then the diagnosis should be considered. The possibility of frontal release signs do suggest the possibility of NPH or vascular etiology. Coming to the investigations, we can do the neuroimaging and look for the MRI brain, in which we can see if any presence of diffuse small vessel disease, that is ischemic changes, and presence of lacunes, which do support the possibility of a vascular Parkinsonism. Ventriculomegaly with tight sulci support the possibility of NPH, and there is a scale, RAD scale, NPH RAD scale, that we have extensively discussed, and the presence of midbrain atrophy showing hummingbird sign and other classical features of NPH can be seen, and any other frontal lobe lesions which could mimic the possibility of a uh, lower body Parkinsonism like presentation. Coming to the management, we have to treat the underlying cause when it is reversible. We have to do ventriculoperitoneal stenting if TAB test positive, and we have also seen data in which there is a TAB test negative, then ventriculoperitoneal stenting has been helpful in patients of NPH. And in case of the diagnosis of PSP, we can give a trial of treatment with levodopa. That is symptomatic treatment with levodopa. It also has modest or poor response in vascular Parkinsonism. Physiotherapy can be given, which is crucial for the gait and postural stability of the patient. We have to address the vascular risk factors aggressively in the case of vascular Parkinsonism. Thank you. Thank you.
Yeah, very good, Mayur. Comprehensive and very extensively covered. Very important topic as well. So
Yes.
over to Divya. Sanu, please unmute Divya. Dr. Divya.
Uh, uh, Mayur, this was a good presentation. You have to read extensively, and the fund of knowledge that you have will always be evident when you're speaking. So this time, I think you have done a good job. You've extensively covered. So in lower body Parkinsonism, it is always a combination of a clinical as well as radiological approach that you have, as you have rightly emphasized. So it's not just that you see a imaging which is suggestive of PSP or NPH. So you have to look at the patient clinically. If you have a lower body Parkinsonism, as you said, these are the three common possibilities will be between PSP, NPH, and vascular Parkinsonism, of which most of the patients on follow up turn out to be a PSP in the commonality wise. So you have to, whenever you see a lower body Parkinsonism, especially you have to emphasize on the eye movements as well as the upper limb signs. So if there is a upper limb rigidity, though the patient may not be symptomatic, if you have a very prominent, at least a grade 2 upper limb rigidity, a grade 2 bradykinesia, a reduced arm swing, or a handwriting changes, as well as eye movement abnormality, especially in the vertical saccades, which can be hypometric or round the eye sign may be present. So if these subtle signs are present, it is highly likely that the patient is going to have a PSP or the other prominent signs of PSP. Now, this is also important in terms of the advice that you're going to tell the patient, especially in terms of falls, as well as the cognition and other symptoms that the patient is going to have. So falls are a very common feature of PSP. NPH can have falls, but it takes quite a long time for the NPH patients to fall. So each of these things, each clinical sign that has to be elicited, and then you correlate with the imaging, because you can have dual pathology. Patients with PSP, clinically we have a prominent, very prominent PSP, and you can still have an MRI which is looking like a NPH. So clinically, what is there is also equally important, and then you correlate with the imaging that is present. Sometimes we have patients who also improve with a tap test. When you have a very prominent sign of NPH and then you do a tap test, patients with PSP also may show a transient improvement. In those patients, it is preferable not to go ahead with a shunt, but maybe 1 or 2 CSF taps itself may transiently improve the gait. So in that case, you can do that, but a shunt may not be warranted because there is a high chance of subsequent falls that can happen. So it's always a clinical radiological approach that we need to follow in these cases. And I think today you have done a good job. And the videos were not actually working. So those signs, everybody has to learn this.
Okay. Thank you, Divya. I think it was a wonderful presentation and very well done. And Divya has tutored very well. Mayur also did a very good job, man. It's very important not only for your exams, throughout your clinical practice, it's very important. Just a question to Divya, just the psychogenic gait, does it um, happen to be at least in some cases mimic any of these gaits?
Yes, definitely. So we see many patients who are referred as Parkinsonism can have a very phobic kind of gait. If patients, especially when falls are very common in the elderly, so once after a fall, then they keep holding on to objects and they have a significant fear of walking, and they can even be wheelchair bound without really having a Parkinsonism. So as Madam suggested, in those cases, examination is important. If you have no features of Parkinsonism, if the leg agility is not slow, there's no freezing. So these may be the clues which may suggest the examination findings may be normal. And in such cases, functional patients we have seen with a phobic gait disorder, which may mimic a functional Parkinson's.
Okay, thank you. So we'll wind up for the day. Yeah, it's a holiday here. So thank you so much.